Okay.
Um, Welcome to National Single Payer's monthly educational webinar, Rural Hospitals Under Fire, How National Single Payer and Global Budgets Can Save Them. My name is Anna Malino. I'm one of the lead organizers for National Single Payer. National Single Payer is a national grassroots organization that organizes locally in the struggle for national single payer healthcare. We are united by the common principles that healthcare is a human right, that healthcare should be free from profit, and that healthcare will be achieved through national legislation. If you would like to support our work, which I hope you do, please donate to our organization. We will periodically drop a link in the chat that you can click and donate throughout tonight's event. Please introduce yourself in the chat using your name and your city, and try to keep the chat conversations to a minimum, but you are more than welcome to please post your questions to our speakers in the Q&A. After our speakers, Dr. Judy Albert will ask questions posted in the Q&A. We will try to get to as many as possible, knowing that we might not be able to answer all your questions, so please forgive us for that. Tonight's speakers, our first speaker is Maureen Tkacik, and I hope that I'm pronouncing it correctly, is a senior fellow at the American Economics Liberties Project, investigations editor of the American Prospect, and a journalist who has written extensively on corporate greed for the American Prospect, the Wall Street Journal, Time, and the New Republic. Her recent expose of private equity-backed Steward Health, owner of 32 floundering hospitals, one of which housed 5,000 bats. Yes, you heard correctly,
That's
bats.
a low estimate, conservative estimate.
Conservative estimate, is resulting in the governor of Massachusetts instructing Steward Health to leave the state as soon as possible. Our second speaker, Dr. Jim Kahn, is professor in the Philip R. Lee Institute for Health Policy Studies and the Department of Epidemiology and Biostatistics at the University of California, San Francisco. Dr. Kahn conducts health economics research, teaching, and advocacy. His research focuses on, among other topics, the economics of single-payer healthcare and Medicare for All in the U.S. You know him as the editor of the Health Justice Monitor, and I hope that you are all subscribers. Along with others, he recently co-authored an economic analysis of hospital expenditures under global budgeting and single-payer financing, which not surprisingly, found that single-payer financing with hospital global budgeting is a reform model that could achieve universal coverage at an affordable cost and facilitate more equitable funding of hospital infrastructure. We've also invited Court McGuffey. Court is a resident of Riverton, Wyoming, a city whose hospital was taken over by corporate greed. He is a member of Save Our Riverton Hospital campaign and board member of the Riverton Medical District. He will tell us how the people of Riverton fought corporate greed and won. So, Maureen, take it away.
When I get started on this topic, there's a lot to explain. I've learned a lot. I started, and I know Court McGuffey. During the pandemic, I got in touch with him because I was trying to learn about private equity in hospital ownership. Knowing private equity ownership of everything else, I assumed it was a pretty bad thing. But the stories that I heard from Riverton, Wyoming, uh, truly broke my heart. And as it turns out, Riverton is one of hundreds of towns that are dealing with a lot of the same just harrowing experiences. This isn't specific to rural hospitals, though there are a few reasons that rural hospitals are particularly vulnerable. And one of the things that, people that really changed the way that I started thinking about healthcare um, is a book from 1967. In 1967, the American healthcare system had a lot of problems that really were vastly different from the problems that we have today. Because Medicare was extremely new. So a lot of the problems arose from the greed of individual doctors and the ideology of the very radical ideology of the American Medical Association. In understanding what our problems were in 1967, it's helped me to understand our problems today, yeah, a lot. And this book is called The Plot Against the Patient, and it's written by a guy who was a mafia reporter. And that is a thing that I really want people to understand, is that healthcare is a crime story. And the problem with large scale reforms of this system is that we do not have any federal institutions that are set up to achieve good outcomes. If you say, gosh, we got to do something, we've got to, do something about drug addiction, do something about our plunging life expectancy in this country. We do not have institutions that are set up to do that, because all of the institutions that we have are set up to make a profit. And it's this is not an ideological thing. I personally, I've been a financial reporter for most of my career, so uh, I know a little bit too much about the way that capitalism works to be a huge fan of it. But it's very easy to come to an agreement with, a lot of doctors and nurses all over the political spectrum. You have to look at the opioid crisis and realize that we should have learned something from that, which is that the that there are areas of the economy in which the profit motive is diametrically opposed to the public health. And if that is not recognized by any institution, um, then that's going to run rampant. And what you're going to get is more sickness. The same thing goes with pharmaceuticals, of course. It is not like, but Goldman Sachs has pointed this out. It doesn't make any sense from an investor perspective to try and develop any drugs that cure diseases. That is why Operation Warp Speed was, frankly, such an achievement, and it needs to be recognized as such. Obviously, the COVID vaccines made a lot of money. Obviously, there's been a big push to get us to, get as many booster shots so that it can continue to make money. But vaccines are not sexy. Drugs that people have to take every day for the rest of their lives are what the profit motive demands, what the fiduciary obligation of anybody running a pharmaceutical company, anybody running a hospital, is to try and keep people profitably sick. This but and yet there is well-intentioned federal, and state money swimming in the healthcare sector. It is a magnet for fraud. And one of the things that was so illuminating about reading this book, The Plot Against the Patient, was that you realize that a lot of the shady practices that in 1967 were associated with individual doctors, individual shady surgeons, doctors, especially in coal mining camps, so doctors in again, rural areas, hospitals that were maybe operated by people with mafia ties. Those practices that they ushered into the American healthcare system, unnecessary surgeries and double billing, billing separately for taking two tonsils out, for kids, and the whole phenomenon of getting removing tonsils. These have been scaled into the system. These have been institutionalized into our system by profit-seeking individuals. Back then, one of the very few good things about the Cold War era American Medical Association is that they were they wanted to keep their power, and they were very interested in perpetuating the solo practitioner business model and making sure that that remained sustainable. So there were, single family doctors who hung out their shingles, and their wives did the bookkeeping. And so in those days, if you had a good doctor, if you had an intellectually curious doctor, if you had a doctor who was, a morally upstanding person, who really cared about, his patients, or later on her patients, um, you could get good healthcare in America. You could also, get, a lot of, when Blue Cross plans came along, there a lot of doctors preyed on union families with good health plans, and there was an epidemic of unnecessary hysterectomies, for instance, in especially in coal mining towns. Um, so there were, you could really get a bad apple, as well, but there was the possibility of getting good care. And what doctors tell me now is that they have to they run up against so much resistance, um, trying to do the right thing. It's just so difficult. It is so they that the only way to really make peace with their lives is to detach a little bit, work fewer hours, maybe take temp jobs. A lot of doctors now like to just travel, especially, emergency room hospital physicians. They would rather just, take high paying gigs, three shifts a month here, 3 shifts a month there, because they don't want to get too invested in a community. They don't want to get to, they don't want to have to deal with, the crap that you have to take if you're a staff doctor, with administration. So corporate medicine, which is, something that did not really exist until the not, that was illegal, in until and these laws were, more or less complied with, until the 70s. That is really, like something that, making medicine small again, making it possible for, good doctors to do the right things, but do right by their patients, making it possible for doctors to see their patients for more than 5 minutes. Those are, and removing, corporations from the practice of medicine. So, removing this business model where, United Healthcare, for example, takes over a medical clinic, alienates all the doctors who work there, but, keeps them by imposing these crazy non-compete clauses, into their contracts, and, replaces half of them with, nurse practitioners, and then, sets up incentives so that they are, pretty much, you know, ordered to systematically deny care of patients who need it, and do a lot of honest to God bullshit, for parents who don't, for patients who don't. You know, Getting rid of that business model, is something that, a lot of doctors, I know, and, on a bipartisan basis, are trying to, do away with, but it's a little bit late. Um, Rural hospitals are something that, I would say that have, for a very long time, and especially today, really exemplify the the worst in of American healthcare. And you can learn a lot about, how it works by studying the kind of the problems that rural hospitals have encountered over the past, few years, or the few decades, I should say. And I think one of the focuses that I have, because there are obviously lots of problems that, plague healthcare, um, across the board, but a problem that I focus on with rural healthcare, because it just comes up uh, so often, is that they are magnets for, um, syndicates of grifters. A GAO report on rural hospital closures between 2013 and 2018, and there hasn't been, I don't think, a very good one since then. But this GAO report on the rural hospital closures, hundreds of rural hospital closures that existed that happened between those in the 5 years between 2013 and 2018, noted that for-profit hospitals were 3.5 times likelier to close than nonprofit ones. If you put that in the South, I think that it went up to 6 times likelier. So there are a lot of rural hospitals in the South that are closing, and grift is a major reason for that. So the official explanations of the rural hospital crisis promulgated by advocacy groups and trade organizations tend to blame low reimbursement rates, the failure to expand Medicaid eligibility. Oh my goodness, all of these red states, don't know what's good for them. But they're strangely reticent on the role of grift in so many of their closures, and this is a big problem. And I found this kind of a little funny. The stuff that you hear, you have to understand that when you're hearing about the problems of rural hospital closures, you have to know who the messenger is. So like on November 12th, 2018, the New York Times published a letter to the editor on the subject of rural hospital closures, authored by the National Alliance of Rural Hospitals, whose president was named Michael Murtha, and it was headlined "The Closing of Rural Hospitals. The Hospitals Trade Group Addresses a Growing Trend." And Murtha blamed the private insurance market for forcing rural hospitals to jump through hoops, sabotaging their efforts to innovate, for what he described as the continued extinction of America's rural communities. Well, the National Alliance of Rural Hospitals was a front group of something called Empower EMS, which, if you might have read, there was some newspaper coverage of this. It was Empower EMS was a hospital chain. So Empower EMS started by a guy named Jorge Perez, who had he was an electrical engineer from Miami. He had owned a lot of private jets, and he'd done some time at his father's medical billing business, and then gotten into this urine testing scam called Millennium, which is another story. But he would go around, he would tour rural America, preaching a gospel to struggling rural hospital managers of saving themselves by establishing innovative revenue streams. Namely a kind of arbitrage scheme wherein the hospitals would set themselves up as middlemen between contract laboratories for processing urine and blood tests for clinics and rehab facilities. And that worked because federal guidelines dating back to the 1990s that permit rural hospitals to charge up to 100 times more than typical pathology departments. Sorry, my kid. Instead of doing something normal, like building hospitals in underserved communities. And this is a problem that dates back to, the Shepard-Towner Act, which was a 1921 law that designed a plan to build rural prenatal care clinics. And the AMA and all of its 1,000 affiliated medical societies just went ape shit, and they would not have it, and they got they got the law defunded, and the clinics all ended up closing down, within about 10 years. So, what would make sense is for, some public entity to have built hospitals in underserved areas where it's not necessarily profitable. In fact, it would make sense for some entity to build hospitals regardless of their profitability, because healthcare is one of those things that, if the health of your nation is good, as Bismarck recognized back in the 19th century, if the health of your nation is good, then, that is a boost to the rest of your economy. And back in the 90s, the Heritage Foundation actually, I think, briefly advocated some kind of single payer system, because it would make our exports more competitive. Imagine that. It would make our exports more competitive. Imagine competitive exports. You could call it, industrial policy. Sadly, what we do instead in this country is we make all of these silly systems, like what is it 540B, the 130B. There's a program that allows certain medical clinics serving underserved communities to sell pharmaceuticals cheaply, but they're allowed to make a lot of money selling pharmaceuticals to underserved communities. There is the sole community hospital designation that allows rural hospitals to charge Medicare on a cost plus basis, kind of old school style, as opposed to the current, DRG system so there's all these kind of ways that rural hospitals that federal policy has tried to incentivize rural hospitals to do little scams to stay afloat. Um, of course, the best scam is that you're in a rural hospital, you've got a captive audience, nobody else is around, and you can get away with whatever you want. And in Riverton, Wyoming, where Court McGuffey, which Court McGuffey can tell you about, their hospital, which was owned by HCA. HCA spun it off into LifePoint. LifePoint was purchased by the private equity firm Apollo, which you'll know from its founder, Leon Black, who's best friends not only with Jeffrey Epstein, but also Harvey Weinstein. Apollo then spun off the poor Riverton Hospital into what we call a shitco, known as Scion Health. Scion Health is on death's doorstep. I just checked its the price of its term loan. It's trading at 20 cents on the dollar. They're it's a total disaster. But this hospital, last I checked, it was charging it was charging an average of 8 times Medicare prices for the very limited suite of healthcare services that it was offering. This is the business model. And so, rural hospitals have since time immemorial, but especially since the 1970s, been a magnet for little syndicates and big syndicates of profiteers. And they have a different set. And one of the things that has made them especially vulnerable is that companies like HCA and community health systems that have over the years, this sort of started in the 1970s. They would kind of go town to town and privatize Hill Burton hospitals. There was actually at one point a federal funding system for hospital construction. That law was drafted by the American Medical Association and I think Senator Taft, best known for Taft-Hartley. And this was sort of the AMA's answer to a national health system. But there were all these sort of little hospitals that had been built, and maybe they weren't really needed, or maybe they couldn't get as much funding as they should have gotten. But in the 1970s, HCA sort of went town to town and started buying off these hospitals that really shouldn't have been legal, but HCA gave $100,000 to a Nixon HHS guy who sort of allowed this loophole to be written into the law. And there you have it. HCA suddenly owns all of these little rural hospitals. Then HCA decides, well, we're going to get into bigger markets. That's really, that's really where you can make a lot of money. The system, especially after the DRG system was introduced, and you were no longer seeing these hospitals billing cost plus to the Medicare system. Instead, they have to, they start really, hiring large folks of people to game the system. And code. These big systems started spinning off their rural hospitals into smaller rural-only chains that had no real connection to one another, where the hospitals had no connection to one another, other than they were all rural, and they all had these captive audiences who really had to pay whatever they were asking. They had a lot of negotiating power with insurance companies, and nobody was really monitoring them for, for fraud. So in the National Alliance of Rural Hospitals, uh, founder was indicted for skimming, $1.4 billion out of Medicaid and Medicare back in 2022. And I think he's in prison now. I believe I've tried to write to him even. He hasn't written back. But this guy ended up collecting something like 25 random, critical access hospitals, all of which he bankrupted. I think about half of which he ended up closing, and those were in Florida and Missouri primarily. LifePoint and its spinoff Scion are in the process of doing that. One thing that I also noted, but just to give you an idea, the National Alliance of Rural Hospitals sounds like a legitimate entity that is selling you, a well-intentioned idea about how to fix the system. Similarly, there's a group called Chartis that puts out a lot of research on rural hospital vulnerability. And how many hospitals, they'll always come out with these estimates of how many rural hospitals are distressed and how rural hospitals need more money. Chartis is owned by a private equity firm called Audax. Audax is like, I don't know a lot. I don't know anything about them. I don't know who owns it. I don't know if he's friends with Jeffrey Epstein. But Audax they put a lot of money into crappy nursing homes. They're ubiquitous in the kind of low rent healthcare space. And that in this, where the business model is very simple, it's overbilling and understaffing. And this has brought us to this real crisis point in this country. And like I said, it's happening. This is happening everywhere. It's happening in cities. It's happening in Massachusetts with Steward Health. It's happening all through Florida. I had a gentleman, a lot of HCA, the for-profit hospital operator, in the 80s and 90s. HCA was sort of known as a nice place, to go for, they'll pay, they charge too much and they would dump patients who were on Medicaid or whose insurance companies didn't pay enough. But the hospitals were sparkling clean and the food was good. Now they are just dumpster fires. And that's, kind of especially in Florida where there's about 50 HCA hospitals. These problems that sort of really started in rural hospitals have become suburban things, urban things. They've started to proliferate throughout the country, but rural hospitals were the proverbial canary in the coal mine, and to that end, the United Mine Workers, our rural hospitals might be a lot worse, except for the efforts of the United Mine Workers back in the immediate post-war period, who sort of forced as a condition of ending a coal strike, they forced the Department of the Interior to conduct a survey of health conditions in the mine camps. Now, this is when the life expectancy of a mine worker ranged between 48 for those who worked underground and like 56 if you had one of the cushy mining jobs. A lot of these camps didn't have running water, and the healthcare was absolutely deplorable. And the United Mine Workers got the Department of the Interior to conduct an incredibly detailed survey, the likes of which you can't imagine any government agency doing today. And that, came with a lot of photos. And I recommend, I highly advise anyone interested in the subject to look those up back from 1947. But that's the only reason that the Hill-Burton that the Hill-Burton Act was even passed, was that the United Mine Workers did such incredible work drawing attention to the plight of patients in the sticks and the contempt that physicians that had for them, because there were a lot of barely licensed doctors kind of who ruled over areas like, little fiefdoms back then. So anyway, that's a bit of a digression, but I recommend that when you think about fixing our healthcare policy, and this goes to the single payer problem as well, right? United Healthcare, there's been a ransomware attack. You might be aware of it if you're following healthcare news. There was a ransomware attack a couple weeks ago on on something called Change Healthcare. It's a kind of a technology company, a clearinghouse. They're a roll up of like 36 different healthcare software and technology companies that handled a lot of claims processing for a lot of state Medicare and Medicaid services. And they do a bunch of things, and they're basically in the back end of just about anybody's, half of the doctors and hospitals in America have their, electronic health record systems or their practice management systems run by this entity Change. And Change suffered a ransomware attack a couple weeks ago, and it's completely crippled a lot of hospitals and especially physician practices. If they have the wrong, and none of these people had ever heard of Change before, but it's completely it's halted their ability to process claims. They can't process claims. They can't invoice anybody. They can't get paid. So I've spoken to quite a few doctors who just haven't had any revenue coming in for the past 3 weeks. And they don't, the service is supposed to start back up again next week. But, in reporting this story, I've talked to a lot of folks who've worked at United Healthcare over the years. It's just got home. For lab tests they process in one of a host of obscure loopholes designed to stabilize the finances of rural hospitals. There are so many special guidelines just for rural hospitals that have been adopted as a result of the lobbying of outfits like this, the National Alliance of Rural Hospitals. And all of these guidelines kind of say the same thing. Well, we can't really give you, state funding. We're not going to actually just, give a funding stream to a community that needs a hospital and prop it up. God knows, we can't actually have the country out there building hospitals where they are needed. So yeah, United Healthcare is sort of, thinks of itself as our single payer. They are very rapidly trying to switch over anyone they can to Medicare Advantage. So the thing that we have, Medicare for all, now more than the Medicare for some that we have, the Medicare for seniors that we have, is rapidly being privatized. More than half of Medicare of seniors are now on Medicare Advantage plans. Medicare Advantage plans are a massive scam. They can be run properly, but the entire premise of them, the incentive structures, all of the theory behind Medicare for Advantage is inherently radically neoliberal, and it is the practices that you will see in doctors, in physician practices and hospitals that are in cahoots with these Medicare Advantage plans are deeply deeply immoral. You'll see, there, like, it is the literal death panel situation. Obviously not not socialist by any stretch. And I've written a lot about that. So we have to save the single payer system that we have, and we have to make it possible. For individual healthcare workers and physicians to do the right thing. It's going to take incremental progress, because the way that passing the way that reform works in this country, the way that legislation works in this country, I mean, I've come to the conclusion, just, over the past few years that Obamacare was like fundamentally like bad. Just I don't think I think that on balance it was bad. I think that it was bad for pharmaceutical prices and what's happened since then. To our life expectancy, to our healthcare costs, to consolidation, we'll bear that out. Obamacare didn't directly cause some of those things, but it indirectly caused most of them. And so I really don't have any easy fix, but I also am deeply skeptical that we can get there. Because I think that even if we pass single payer, United Healthcare would run it, and they would run it for a profit. I don't know how you banish um, profits from people. There's so much confusion over like, well, but like I have to be profitable. I'm a doctor. I'm a practice. If I don't.
Looks like Maureen is frozen. Maybe what we can do is let's go ahead and move on to Dr. Jim Kahn, and hopefully Maureen will get her internet back. And then after Jim, we'll have Court. Go ahead.
And wow, I was really enjoying listening to Maureen. The notion that that healthcare is a crime story is one I'm gonna mull. I think there's a lot of truth to that, and certainly healthcare has been an opportunity. Maureen, I was just saying that health your starting point that healthcare is a crime story is very interesting, and I think unfortunately there's a lot of truth to that. There's ample opportunity in the massive amount of money. Nearly 1/5 of the U.S. economy goes to healthcare. There's all of these opportunities to steal money from healthcare, often while thinking or appearing they're doing good, but the focus is on taking actions that bring in money. I will very quickly take issue with your point that United Healthcare would run single payer, because the single payer bills that I know would not permit that. So I think it's all in the legislative action, which of course is fraught for sure. But anyway, my charge today was to talk about the role of hospital global budgets in the context of saving rural hospitals. So I'm going to do my best. As a disclaimer, I know a little bit about the rural hospital challenges, and but more about global budgets. So let me just dive in. I have a dozen or so slides, so I'll just walk us through those. First of all, here's gives you a sense of the scale of rural hospital closures. You can see from 2005 to 2022, there are a total of approximately 200 rural hospital. Ooh, how did that happen? Let me go forward. Rural hospital closures. The red ones are more recent, and the gray ones are over the up until 2019. There remain many rural hospitals at risk. This is the percentage by state of the portion of rural hospitals that are at risk. In Connecticut, it is all of them. Hawaii, 75%, and so on. These are the states with the highest exposure for rural hospitals, according to this particular assessment. Why is this happening? One of the reasons is that different kinds of payers pay different rates for hospital services. So the Medicare rate is indicated at the bottom here, and then we look at average private insurance rates. They are much higher in varying degrees for overall for hospital services are about 200% higher from 141 to 260%. And this applies for inpatient, especially for outpatient, and a little bit less so for physician services. So depending on the payer mix, this can make a big difference to the hospital bottom line. And what's not shown here is that Medicaid can pay less. So if you look at the profile for payment sources for hospitals that are struggling, the struggling ones are here with this kind of a light green. The struggling hospitals tend to have a lot of Medi-Cal days, and they have a decent amount of Medicare days. They, as you can see here, and all other hospitals that's the blue ones tend to have the most number of private days, and that goes along with the slide I showed you a moment ago, that the private payers are paying a lot more for the hospitals. So the hospitals, like private payers, are not enthusiastic about Medicare payers. And so, again, struggling hospitals have a less favorable mix, more public, and also some unpaid days. That said, the role of Medicaid, in particular Medicaid expansion in supporting rural hospitals, is important. What we see here is that the operating margins are better for hospitals with the median operating margins. For hospitals in blue, which have expanded, are in states that have expanded Medicaid. So states that expanded Medicaid, 3.9% operating margin median, and non-expansion states, 2.1%. If you look here at the margins without relief funds, which I'll show you in a moment, like COVID-related relief funds, the hospitals in non-expansion states are losing money. Obviously, that's not a formula to stay in business. So absent COVID relief, those hospitals in non-Medicaid expansion states are in the red, losing money. That's a critical issue. So Medicaid does play a meaningful role here. The money that came through during the pandemic to help with rural hospitals did reduce the closures. So you can see that the annual closures were in the range of 15 to 20 for the years preceding the pandemic here. And then during the pandemic, much less. So that money, of course, which is either gone or going away, was instrumental in helping rural hospitals. So then, now that we're past that period, the crisis is then back in place. How do other countries deal with paying for hospitals? They have a variety of methods. We have done a study, which we're in the process of publishing, looking at a variety of features of other wealthy countries, the countries in the OECD, which is the Organization for Economic Cooperation and Development. There are about 32 countries that we looked at how they pay for healthcare, various aspects. And one of the aspects was, how are they paying their hospitals? And about half of the countries, exactly half actually, use global budgets to pay their hospitals. A little bit fewer use diagnosis-related groups, which is similar to method used in the United States, and a few paid by procedures. So it can work to use different methods, but half of the wealthy countries around the world use hospital global budgets. So if anyone tells you this can't work, you can tell them, but it does work. In general, I would say that, for me, is the most valuable part of studying what happens in the OECD, other wealthy countries, to be able to say, hey, don't we believe in evidence-based medicine and evidence-based policy? These methods to pay for healthcare work around the world. This isn't news, but we get into quite a bit of detail in this look at the 32 countries. Stay tuned. Hopefully, we'll get that out there soon. So, what is a hospital global budget? As conceived in the United States, in the single payer plans that I've looked at, under a hospital global budget, the hospital receives an overall operating budget, which covers primarily salaries and supplies, but any other operating costs as well. This budget is set based on past clinical use and costs. In the past budget is reduced to eliminate the profit component. I'll come back to this quantitatively in just a moment, but reduce to eliminate profits and to reflect the fact that the administration of the hospital is simplified by not having to bill for each individual service or each individual patient. Also, these operating budgets are going to have to be a little bit higher to reflect the fact that when people have better insurance, they're likely to use hospitals a little more often. And according to other research we've done, the increase in hospital utilization is on the order of 0 to 3%. So in the numbers that I'm going to show you in a minute, we assumed a 3% growth in clinical utilization. Hospital budgets also allow for growth over time at a controlled rate, usually the same rate as the growth in the GDP. And this reflects changes in the prices as well as reasonable growth in use, for example, due to the aging population. These hospital budgets are adjusted within any given year for unexpected contingencies like a disease surge. So hospitals are, I guess you could say, held harmless to factors that affect their costs. And in contrast, if you have a situation where hospital utilization goes down, which actually happened during the pandemic, people were staying away from hospitals because of fear of contagion, understandably, the hospital budget the hospital would not be left without funds and would not be put in a position of going bankrupt because they don't have business. Importantly, in hospital global budgets, as contemplated for single payer, there would be no billing per service or per diagnosis, and that's efficient and simpler. Secondly, capital spending, such as for new buildings or large new diagnostic equipment, is excluded and it is instead budgeted and decided separately from the operating budget. So that's the general idea. So a few of us, led by Adam Gaffney, former PNHP president, and also participation by Steffi Wohlhandler and David Himmelstein, PNHP founders, and myself, we looked at what the hospital budget in the United States would look like if we switched to global budgets. And this is a lovely graphic made from our article by a colleague, Ed Weisbart at PNHP. So you start with, because this graphic goes from 2021 to 2030, I think is, yes. 2030 is not labeled, it's this last year. And the numbers here on the vertical axis are billions of dollars. So this is 500 billion, 1,000 billion, in other words, $1 trillion, 1.5 trillion, and 2 trillion. By the way, Anna, I sent you the PowerPoint. Anyone who wants a copy of the PowerPoint, including this cool animated graphic, please feel free to share that. And so we started with the current trajectory as predicted by the National Health Accounts, which is something you can easily get from the U.S. Department of Labor. It's really cool, both historical and spending and projections cut, sliced every which way. And if you're interested in what we spend or what we think we will spend on healthcare, that's the place to go. So we looked at the trajectory, and it had spending going from 1.3 trillion in 2021 to an estimated, I think it was 2.5 trillion by 2030. And then we looked at what the budget would be under single payer. The difference is, now I'll show you. First of all, this green section, which almost but not quite reaches the green line, is the cost of single payer if there were no increase in utilization. So just those clinical operating costs. But as I mentioned, we assume, based on the evidence, that there's a roughly 3% increase in utilization, not more, if you give everyone better insurance. So that's this thin blue line right here. So that gets us to this total projection for single payer spending. So what makes up the difference between the single payer trajectory and the hospital trajectory without single payer? Well, first of all, foregone profits and marketing. So we know from the reporting that we had access to how much of hospital income goes to profits and marketing, and so we remove that. And you can see it grows over time a little bit because we expect a small growth, as mostly as a function of the growth of the underlying utilization. And then there are very substantial administrative savings. Right now, hospitals are spending something like 8% of their budgets on dealing with billing-related administration. So writing contracts with insurers, monitoring the kinds of things that are necessary for billing, preparing and submitting bills, et cetera, et cetera, et cetera, many, many different tasks. And most of that would go away. It wouldn't go away immediately. So we, as you can see, we assume it would take, I think, 5 years to grow to the maximum savings, which is right about here, and then you continue those savings going forward. So that's the biggest chunk of savings, is simplifying administration. And finally, reduced growth rate. So I mentioned the rate of growth is controlled under global budgets, both at the institutional level or the hospital level, and also for the system as a whole. And so if you add all of these up, you can see that the savings achieve something approaching $2.5 trillion. That's a lot of money. That's through global budgets. What are the effects of hospital global budgets? First of all, efficiency. Obviously, reducing administrative costs associated with billing, eliminating profits, including marketing, and also no profit-focused expansion. So right now, oftentimes, hospitals will expand not because there's a community need, but because they see an opportunity to provide services that are lucrative. You might call that criminal in certain circumstances. I'm sure there's plenty of misrepresentation, but it is certainly exploitive. Quality. So there's a focus on improving and tracking clinical quality. What I didn't mention, but is included in the what we assumed, is that there is a small increase, not only for increased utilization, but for better clinical monitoring of clinical processes and outcomes. So you get more money to improve quality. Stability, and this is a critical asset of hospital global budgets. There's a guaranteed budget with any adjustments that might be necessary due to unexpected increases or decreases in demand. The hospital is no longer vulnerable to changes in payment rates or changes in their ability to attract patients and so on. Equity, these global budgets will work for any patient population, in any location. So rural settings will be protected. Hospitals that serve poorer populations will be protected. And finally, communities. Hospitals here are treated as a local resource. They're not treated as a profit center. So all of these aspects of hospitals are fostered by going to a global budgeting system. Many of you have heard of what's going on in Maryland, which has been going on for quite some time. In 2014, so 10 years ago now, there was a shift from all payer reform, which meant that that all payers were paying the same amount, to hospital global budgets, kind of. So it is true that for the last 10 years, hospitals in Maryland have had global budgets. However, they still use all payer payment rates. And I put a question mark here because honestly, I couldn't figure out how you reconcile global budgets with the fact that they still use all payer rates. It may be used as a way to calculate what the global budget is. Like, you know how many people at the hospital are insured by Medicare, and you know what services they got, and so you calculate the global budget based on that pattern. It's a complexity, makes the whole thing a little bit less efficient. There are two major factors that really distinguish the Maryland approach from what I'm talking about for single payer global budgets. First, hospitals still earn profits in Maryland. The single payer model that I just described eliminates hospital profits. So, big difference. Secondly, it's a little more subtle, but it's also really important. In Maryland, hospitals still need to submit detailed financial as well as other types of information for each patient. So that efficiency that you saw was, I'm going to see if I can go back to it. This big slice here for administrative savings, that doesn't happen in Maryland because you still need to submit all of this detailed information. So Maryland, should be credited with moving the discussion forward, but not with having achieved true global budgets in a single payer sense. And that's it. That's all that that I wanted to contribute to the conversation. And so I turn it back to you, Anna, and to Maureen, etc.
Thank you so much, Jim, and thank you so much, Maureen. Welcome, Court. If you would like to let us know what's been going on in Riverton, that'd be great.
First, thank you for having me. Again, my name is Court McGuffey. I live in Riverton, Wyoming. Maureen, I know you as Mo, I think, from a couple years ago when we visited, and it's good to see you, and thank you for your presentation tonight. I am the board chair of the Riverton Medical District, which is a grassroots effort that started in Riverton about a little over 5 years ago. And we are coming up on 6 years. I know, Dr. Anna, you said that we had taken on corporate healthcare and won. We haven't quite won yet. We are very close. We are actually out to bid on a brand new hospital facility here in Riverton, Wyoming, and we'll get our bids back here on April 2nd. And if we're still on budget, we are good to go. And we're building a brand new facility here to basically replace the hospital that was basically gutted by corporate health care. Just a little bit about me before we get going. I grew up here in Riverton and graduated from high school here in 1995. And then I do have a little bit of a medical background. I was a dentist in my former life. I'm still a licensed dentist in Wyoming, but I sold my practice and moved back to to Riverton about almost 6 years ago now, but I practiced dentistry in Greeley for about 12 years, Colorado, and wanted to raise my family back in Riverton. When I was growing up here, we had a great hospital, 25 providers. It's a town of about 10,000 people. And in just a little bit of history, and I know I don't have too long here, but the Riverton Hospital and Lander is a community about 30 miles away. They, in the early 80s, the counties decided to sell the hospitals. They wanted to get out of the hospital business. Lander had tried to start an open heart program that didn't go well, and the county felt like they were going to be liable for some things, so they sold him. And that was kind of our first mistake, but it worked for a long time because, just like Maureen said, we had different for-profit companies owned each facility. And so I think Lutheran Homes owned Lander and HCA owned Riverton, and then they sold to LifePoint, and they changed ownership many times, but they worked, and it worked for a long time. And I had great hospital care in Riverton because they competed against each other and they supported each other, and kind of kept each other in check. Well, that all changed in the late 2000s when LifePoint ended up buying the Lander facility as well. And about 4 or 5 years later, I call it the beginning of the end. But they basically they tried to sell the communities on centers of excellence between the two hospitals. And, where they might do OB in one hospital, they do orthopedics in the other, and vice versa. But it basically turned into gut the Riverton Hospital. And, they shut down OB, and then behavioral health and general surgery. And so now we call our hospital an ER transfer station. And we went from about 300 life flights out of the county to over 1,000 when that change occurred. And so, that's an average of over 3 life flights a day. And we're not talking for serious stuff either. It's for appendectomies and broken arms and stuff that shouldn't be life flighted. So anyway, we tried to work with LifePoint and to see if they would change things, but they didn't. And the people here on the ground, they're wonderful people that are working in just a bad situation, because they don't have any control over what happens here. It's all the people back in, well, now it's in Kentucky, because that's where Scion Health is, because they spun off. But at the time, it was Nashville, Tennessee, where LifePoint is. And so we decided to build our own. And it took us about 3.5 years to basically convince the USDA that we didn't have services in Riverton. And we got a tremendous amount of support from our local politicians and leaders and the governor, and but we raised about $6 million locally. We've partnered. Riverton is right in the middle of the Wind River Indian Reservation, which we're in a blue collar area in Wyoming. We haven't been quite as blessed with some of the energy resources that other parts of the state have, and we don't have the tourism that, of course, Jackson Hole has here. So we had to work hard to raise that money, and we actually formed a partnership with the Eastern Shoshone tribe, which is one of 2 tribes that live on the reservation here. And they donated some land to us that they had purchased from the state of Wyoming. It's not tribal land. They purchased it as a investment, as a business development. And so that was part of our $6 million. We raised about $2 million locally. We passed a 1/2-cent economic development tax, which taxes in Wyoming are very difficult to pass. And it won by about 50 votes, which is a landslide here in Riverton. But the big reason that passed is because we got about $1 million of those dollars to go towards our new facility. But so we've been recognized by the Wall Street Journal for our efforts because, like Maureen said, this is happening all over the country. And when the author of the article, he's written 2 on us now, but the first one came out in 2021, a couple years ago now. But when he called us up and, he started like finishing my sentences on exactly what was happening here in Riverton as far as, Apollo buying out Life Point, and then Medical Properties Trust coming in a year later and purchasing the real estate to suck out all the assets. And then, then the hospital's having to pay an exorbitant amount of rent that they didn't have to pay before. And but anyway, he just said that we were one of the only communities in the country that was doing something about it. And so they wrote a great piece on us, and that gave us a lot of credibility moving forward, especially with USDA. And yeah, we're really proud of our community and what we've done. It's been a total grassroots effort. I know more about private equity and healthcare than I care to ever know. But we're doing the right thing, and we're almost there. I pray we're still on budget here in a few weeks and we can get started with our groundbreaking, because it will, literally change our community forever, I think. And we do have a community college here, which was built about 35 years ago, and this will be the biggest thing since then in our community. And we've partnered with Billings Clinic out of Billings, Montana, which is just a really great hospital group, a nonprofit. We were hesitant about getting together with anybody after our experience with LifePoint, but we were smart enough to know that we weren't experts in running a hospital, and they've been a great partner. They believe that healthcare is best done locally. They didn't want to own us. They wanted to support us, and so they've been a tremendous asset to us in this journey. And I won't keep going on, but yeah, I just thank Dr. Anna for having us. We had a great conversation a couple weeks ago. And just one quick aside to your guys' group, the National Single Payer. I came back to Wyoming to run 2 small transportation businesses. We employ about 75 people here, and our healthcare premiums just went up 40% this year. And it's been super tough. We want to do the right thing as business owners and, provide insurance for our people, but it's unsustainable. And we've had, Obamacare's been good for some folks to get people covered, but it's put more pressure on those people that are providing private insurance. And so for small business owners like us, I mean, every year it just seems, I hate it when my insurance lady shows up in October and November, because it's usually not great news. And we just try to figure out a way to keep our coverage for our people. So it's a real challenge, and it's something that's unsustainable moving forward. But with that, thanks again for having me, and happy to answer any questions.
Thank you, Court. And right now we're going to have Dr. Judy Albert, who's been looking over the Q&A. She's going to start asking our panelists questions. But thank you, Court, for your presentation.
No problem.
I just thought maybe, thank you to the panelists who presented such interesting views of what's going on with the rural hospital situation. I thought maybe we would give Maureen just a brief moment to wrap up, since her internet froze her out. Does that work for you, Maureen? Just a couple minutes, maybe?
Sure. I wish I knew what I was talking about when I got kicked off. Um, I just, it's such a terrible spiral. It's uh, s- uh, watching uh, Jim's presentation. I guess the issue that comes up for me is that doing reforming our healthcare system requires we us to really outlaw a lot of extremely profitable middlemen. The pharmacy benefit managers, of course, United Health, the revenue cycle, the revenue cycle consultants, the payment processors, the claims adjustment people. I mean, there are these in entities, are estimated to take, like a third of our healthcare system. There's so many that you've never even heard of. You can't even believe, and they all exist. They all will tell you they exist to help, hospitals and insurance companies with cost containment. But what they really do is they take some cut of the overall pie, and they want that pie. They want the cut to go up, and they want the pie to go up. And this has been, United Healthcare, and United Healthcare is literally um, a direct product of the HMO Act. So, I saw a question about HMOs, and I got to tell you, um, HMOs were, they were sort of invented by this guy Paul Elwood. His protege was a guy Richard Burke. Richard Burke founded United Healthcare, and he founded it in direct violation of a law that the state of Minnesota passed in 1974 because they didn't want their HMOs to go the way of California's HMOs. But in but they did, because this guy, basically got a contract to run the HMO for the physicians of Minnesota, and before long he was taking an 18% cut of the revenue, and he was too rich to take on. So that's how that story began, and now it's almost a half a trillion dollar company. So I it's hard to go up against half-trillion-dollar companies. It is hard to try and outlaw their business models. Uh, I would I I know that this country has done stuff like that before. The AMA actually got its start going up against the Patent Medicine Trust, which had in turn sort of, taken America by storm during the temperance movement, because doctors, like, snake oil salesmen could sell, cocaine and heroin to to people and call it headache powder, um, and because they were so powerful, they didn't actually ever have to print their ingredients on their labels. So people were getting hopelessly addicted to cocaine and heroin in rural America, because especially because the temperance movement was strong, and because hospitals were not very good in rural America. So a lot of people, their healthcare was cocaine and heroin that they didn't know they were consuming. And the AMA got its start taking that on and busting the Patent Medicine Trust. That was in 1906. And so, I know, that I mean, obviously we did prohibition. I know that we have outlawed industries before, um, but it's going to take a lot. We have to, the Medicare Advantage middleman is the most insidious now, because you go on a Medicare Advantage plan, and what a lot of people don't understand is you go off that whole pre-existing conditions thing that doesn't apply to Medigap plans. So once you're on a Medicare Advantage plan in 46 states in America, you are stuck in that plan, or stuck paying, 20% of your medical costs. Um, so we have to the answer that I can see is before we do any of these reforms, we actually really have to weaken these tyrannical, parasitic middlemen that takes so much that they're constantly giving us less for more. I mean, why are courts, employees' premiums going up 40%? Well, it's because they're hospitals, the only hospitals in that area, and it's like two hours to Casper, I think. The hospitals in that area are owned by a rapacious private equity firm, and they charge 8 times the Medicare rate, and they, you know, don't actually do all that much anymore. So people get very sick. Um, we have to really vilify, I think these, and and people are ready. I mean, I just got a call from a random 88-year-old yesterday who wanted to just rant about United Healthcare. I don't even know how she got my information, but you know, people understand. I don't think that people are so besotted with for-profit healthcare. They need to understand who the villains are, and we need to take them down. So that's my piece. And God bless all of you for for showing up.
Thank you, Maureen. And you did kind of, that is right about where you were, I think, when you got cut off before talking about how do we do this. And this is the fundamental questions that we at National Single Payer are interested in dealing with. Is it incremental? How do we do this? How do we build a movement so that we can educate the public and expose all these profiteers? So that is the direction that we wanted to go. And now, after looking over the questions, I'd like to go to the questions. Going back to how Maureen started with this being a crime report, and the fact that there is no overarching federal body that that regulates this situation. The first question I had regarding that was, would the CDC be the government agency concerned with health and the practices in rural and low access hospitals that are creating these dangerous situations for patients? I don't know if Jim, you want to take that question, or Maureen. I don't know that there's an answer to that. I don't think it is the CDC. Um, uh, if anybody else has of the two of you has an answer about what that would be.
Yeah, yeah, there, the federal health bureaucracy is divided, and sort of depends what the type of problem is. Obviously, if hospitals are doing something that's creating a health hazard, one candidate to address that could be CDC, but you could also have the Center for Medicare and Medicaid Services, or CMS. If the problems are with Medicare or Medicaid funded services, they could jump in. I don't think it's about which agency. I think it's about the political will. And if there is, if the urgency to address fundamental problems in the structure of how we pay for and deliver healthcare is there, because somehow or other our elected officials decide that it's important. If that could happen, then I think they could take that to one of several different federal agencies. It's really all about who controls the actions of the people who make the laws that drive the agency missions.
Exactly. Maureen, did you have something to add?
Um,
You're muted.
we so in the 1930s, and in the trust busting era, there was a lot of understanding that if there were certain industries that were natural monopolies, railroads, utilities, and there was a big push for comprehensive, well thought out regulation of those industries. This is something that the AMA, starting in 1919, resisted with every fiber of their being. And so unlike all the rest of unlike the airlines and trucking and trains and, airlines, there's never been comprehensive hospital regulation. We do have this thing, the Joint Commission. It's a kind of quasi public-private entity. They're the ones who actually inspect the hospitals. So, during the coronavirus, Trump CMS director realized that she didn't actually have the power to order, spot inspections of hospitals, their infection control protocols. CMS is an unbelievably toothless agency that is they're not allowed to fine hospitals. They can take a hospital's funding away. That literally never happens. So they don't really have any tools for policing our healthcare system. This is a lot of our healthcare system. We don't have a regulator. We do need to make a new one, and it will take political will.
Right. I think it fundamentally goes back to the political will. And one of the questions was, I think this would possibly be for Jim, what percentage of hospitals and hospital chains are part of an HMO or other corporate entity that combines the treatment and financing functions? What impact does this have on the overall cost and efficiency?
Sorry, I think that was a multi-part question. Can you read that again?
What percentage of hospitals and hospital chains are part of an HMO or other corporate entity that combines the treatment and financing functions?
That is two questions. And so, yeah, so I don't know the answer to what percentage of hospitals are part of chains. I think it's the majority, but I am not familiar with those numbers. So we need to look it up, which I can do while we're talking if we want. In terms of combining the care and finances, I think that's a question about the role of capitation. In other words, how many hospitals are accepting financial risk as part of their business model. And I also don't know. I also don't know that answer, so I'm striking out 0 for 2. Throw me a third, I'm sure I could totally strike out. There's plenty of active debate within the single-payer community about whether any kind of capitation, which in effect means the provider is taking some sort of financial risk, would be okay under a single payer system. And I won't engage in that debate now, but that's an important question.
There's a question for Court, and that the question is, do you plan to use global budget for the hospital? I guess another way of saying that is, how are you planning to finance the hospital as it goes on? Is Court still on the call? I'm not seeing him on my screen anymore.
I just made him, yeah.
Oh, there
I
he
think that now he should be able to have video as well, but if you wanted to unmute Court, yes, I figured it out. It was totally my fault.
I jumped out of the meeting to see if it was my camera, and then so how are we going to fund it? I think was the question, right, Judy? So right now it's a $54 million project. We've raised a little over $6 million on our own, and then our USDA loan is for $37 million. It's the largest USDA community facilities loan ever in Wyoming, so we're pretty excited about that. We got a $1 million grant for equipment from the USDA, and then we received $10 million from the state and ARPA funds. Our USDA loan was contingent upon us getting that money. Wyoming got $1 billion during all the COVID stuff, and they carved out some of that money for capital construction projects for healthcare, to help treat COVID, and we were able to. A lot of work went into that legislatively to get that done, but we got that done. So that's our $54 million budget, and yeah.
Um, as far as avoiding the problems that exist in rural communities, do you have any specific plans for that, such as staffing challenges, maintaining all the services that you want to have?
Yeah, that's a great question. A lot of people ask that question. I think I read a couple of the comments in the chat, and Kathy from Minnesota. It sounds like kind of the same thing is happening in her community, but we know staffing is going to be a challenge, but we have one of the best nursing schools at our community college in the state, and right now Scion Health isn't using that like they should. A lot of our nursing students have to drive to Casper to do rotations because there's nothing going on here for them to learn. So we really want to partner with them. Our relationship with Billings Clinic, I think, is going to be huge. There'll be a collegiality there with physicians. They're going to help us recruit doctors. We're waiting until we actually break ground before recruiting physicians, because then we know when this thing will be open. But we have a lot of great people that are working in our facilities here that are just waiting for us to get open, to join us. So it's going to be a lot of hard work, I know, but when the whole community is invested, and that's a challenge I'm willing to take, is to recruit physicians and recruit nurses, and I think a brand new facility, and and you got a community behind you that is going to support you like probably no other. The USDA told us they've never seen a project with as much community support as ours. So we know it'll be tough, but it'll be worth it. The alternative right now is that's what keeps us going is, if we do nothing, we're stuck with this outfit that doesn't care about us one single bit. All they care about is shareholder profits, and they're not going to change anything. And our people are literally dying, because they're making split-second health decisions. You guys are physicians on here, and time is tissue. And right now we have people hopping in cars and driving 2 hours that are having heart attacks because they just don't want to be life flighted somewhere. And so that's just not good enough. And
could you see a place for a system like a global budget? I know it's difficult to think about how you would enact that in a small situation like that. That's actually what the questioner was interested in.
We haven't thought about that much. I've probably thought about that more through my business, talking about our 40% increase in premiums this year that we've experienced. But we want to make enough money to keep the doors open. And whatever that looks like is what we're going to do. For us, it's just so important to get the local control back again, to where we have a say on what's important to us. And so, if we need digital mammography here, we're going to spend the money and get it. Or if we want to support different programs, to increase the health and well-being of our community, we're going to be able to invest the money to do that. And we're just going to make enough money to keep the doors open, and keep investing. But yeah, the current model, I mean, it's all about profit right now from these for-profit private equity backed companies, and we want to change that.
I think we might have time for one more question that was asked in a couple of different ways, and that is one of our participants talked about how their rural critical access hospital has such a low volume of obstetrical patients. It's difficult to sustain those kinds of services. And also, at the same time, in an aging population of their county, they have the needs for joint replacement and other orthopedic surgical specialties. And so, one question for Jim is how would the single payer global budget model account for the being able to have these various types of services that end up being low volume in a critical access setting?
Good. Well, I don't know the specific answer to the question of if you have 4 births a month, exactly how that would be handled. But the point is, there would be an explicit and open decision. For example, family practitioners who do a lot of other things often also do obstetrics. So maybe you would just make sure that that hospital has adequate staffing with a family practice doc to provide obstetric services. And that might mean a decision to recruit to that hospital someone who's qualified to do that. Or it may be that there are nearby hospitals within reach where there would be a contract to, as long as it's not too far. But the point is that there would be a commitment to providing that service, and it would be figured out in a way that makes sense. By the way, I'll just add about the earlier question about percent of hospitals that are in hospital systems. I just found it, it's about, according to what I found, it's about 70% are part of systems.
Great, thank you for looking that up. I'm not sure if people saw in the chat, Maureen did have to leave, and we are at the end of our time frame. There are many more questions that we really didn't have a chance to get to. I'm going to pass it to Claire now to close us out. As Anna said, that the video is being recorded and will be available on the website. And thank you so much for everybody who participated. So off to Claire.
Okay.
Can I,
Thank you,
Yeah, Jim,
I just want to say if people have further questions afterwards, feel free to email me at healthjusticemonitor@gmail.com. Healthjusticemonitor@gmail.com, and I'll get back
Thank
to
you
you.
so much for providing that.
Yes. Thank you, Maureen, although you've already left, Jim, and Corte for this very informative and interesting conversation tonight. And thank you to everyone who joined our presentation tonight. Let all your friends know about it and invite them to our next one. My name is Dr. Claire Cohen. I'm a child psychiatrist in Pittsburgh who's on the steering committee of National Single Payer. If you'd like to support our work, please donate to National Single Payer and use the link in the chat to donate. You can also go to our website, www.nationalsinglepayer.com, to sign up for our email list and our monthly newsletters. Join us Wednesday, March 27th at 5 p.m. Pacific Time, 8 p.m. Eastern Time, to continue our conversation on how to achieve National Single Payer. And join us Wednesday, April 10th, for our next educational seminar. Thanks again for being here, and we hope to see you the second and fourth Wednesday of every month. Thank you, and good night.
Thank you, everybody.
Thank you.
Thank you to our speakers, Jim, Court, Judy, Claire, and Maureen. See you next
Thank
month.
you.